Hi everyone, I'm Chandani Shah Motwani, your host, and today I'm very excited to have with us Damien Mullick. Is that how you say the last name, right? Damien Mullick. I've been going to him for a few years now, and he's not only a practitioner here in Hong Kong, but in my opinion, a true game changer in health, and to me, a bit of a magician. So thank you for being with us today.
Pleasure.
So let's just dive straight into this. A lot of people don't really understand what osteopathy is. They think it's a lot about cracking backs or fixing your neck, but they don't really understand that it's really a holistic approach to health. So, in your words, could you just share a little bit about what osteopathy is?
So osteopathy is actually a medicine. It's called osteopathic medicine. And if you go back in history, it's been invented by general surgeons and GPs in the 1800s, especially one, Andrew Taylor Still, who changed the concept of medicine, who said, instead of treating the symptoms, we're going to try and start to treat the cause. So basically you study the anatomy and the physiology extensively to make sure we come back to the root cause and the cause and effects in the body. In the States, osteopathy is a bit different. Most osteopaths are GPs, general practitioners. In Australia, when you're an osteopath, like with my training, you're a primary healthcare practitioner, you're a physician, you just can prescribe like x-rays and so on. But in some other countries, osteopaths are regarded more of people like backcrackers or a bit like a little bit obscure treatment, a bit of body work. Not sure. They were a little bit suppressed when they came to Europe in the 1900s because the medical body didn't really want the osteopath. So in the world, you've got different types of reputation with the osteopath.
Yeah,
In the States, an osteopath can be a surgeon.
exactly. I've had DO as
So
doctor.
it's the same. So it depends on the country. But the key with osteopathy is just basically you just study extensively anatomy and physiology,
Okay.
and you work out what is the cause of the problem and the chain reaction.
Okay.
So sometimes, because you know the anatomy quite well, you can just say, oh, okay, this causes that. It's basically physical vectorial force that cause and effect, and you go up. The hip compensates to affect the shoulder on the other side. So if you loosen up the hip, decompress the pelvis, the shoulder will loosen up through latissimus dorsi that's loosened up. And it seems, wow, that's a little bit strange. Like this guy just pulls on the hip, moves a bit the pelvis, and my shoulder frees up. So for us, it's common sense.
Yeah, okay.
For the patient,
It's magic.
it's a little bit magical.
Yeah.
Now, there's different types of osteopathy, as you've experienced.
Yes.
This osteopathy is more like a cranial osteopathy where you listen to the body. There's structural osteopathy where you move things directly.
Yes.
There's visceral osteopathy where you look at the viscera and you see how the viscera is functioning, how the fascial connections are just attaching to each other, how the valves are working. And there's work of orthopedic testing. There is a work of basically checking symmetry, tissue texture, and range of motion. And there is also a work of listening to the rhythms of the body, like cranial osteopathy, which is listens to craniosacral rhythm. Biodynamic osteopathy, which listens to how the fluids, the protoplasmic changes in the body occur, and how the body can change from a more solid to a fluid state with heat, with a reorganization of the fascias.
Okay, so what I heard what you said was cranial osteopathy is one type, visceral osteopathy, and what was the other one?
Structural osteopathy, where you manipulate, you crack.
Yeah.
You've got functional osteopathy, where you just look at where the body wants to go and find basically the ease in the tissues, in the planes. This is all osteopathy. It's not, you can't differentiate those different types of osteopathy. When you learn as an osteopath, it's a 5-year degree in most countries, you learn all those types of osteopathy. So you learn everything. I believe that we have a bag with lots of tools and we need to adapt to the patient, how the patient feels. I am not going to start doing some cranial osteopathy on a weightlifter. It's not going to work.
Oh, interesting.
The guy comes up really muscly. First treatment with an osteopath, if I start treating cranially, he's really bind up really tight, the tissues are really tense. I need to loosen him up.
Okay.
I need to just get something more physical. There's a meeting place where you can trust me and we can move on. If I start checking his cranial rhythm, he's going to sit there going, what's he doing? What's he doing? What's he doing? He's not going to be receptive. His tissues are not going to be receptive. He's not going to be receptive.
Why won't his tissues be receptive?
He's a guy that lifts a lot of weight. His muscles are tight within his muscle envelope. His connective tissue is all bound up. He's got no space to move.
Okay.
He wants to be mobilized and move and decompressed.
He's already has so much tension in his...
He's already tight like this.
Well,
you have to...
You can say that about postpartum moms as well.
That postpartum mums, it's a little bit different.
Yeah. Okay.
Because in postpartum mums, you've got to take into account what kind of birth they had, whether they had a C-section or not, whether they really highly stressed from being a new mum, whether they're quite casual about it, whether they've got problems breastfeeding or not. It's just a little bit different. So you got to read the room, read the patient, and feel what they actually need. So sometimes you just have to hold the space for a bit. Yeah. For the person to just come to you.
Interesting. Okay.
Can't force things.
So it's really about the cause and effect between your anatomy and physiology, the function between that.
One of the principles of osteopathy are, the main ones are, the body is a functioning unit. So you have to make sure that the body functions as a whole. Okay. Okay, the structure governs function. So you make sure the structure is right so that the function just comes afterwards. The rule of the artery, so you have to make sure you have a good blood flow to all the tissues, because if you don't have any fluid to the tissues, nothing works. And the body's got the ability to heal itself. It's pretty simple so far. Right?
Yeah, the ability to heal itself. Yeah.
So we've got everything in the body, right? The body's ready to go. Why is the liver not detoxifying? Is it because the liver is tight under the diaphragm, is mechanically compressed? Is there a drainage issue? Is it because there's gallstones pushing up and the drainage is reduced? You have to consider nerve, arteries, veins, blood supply, drainage, and nerve supply. Everything that is mechanical in the human body often has a chemical or neurological output. If you tap a nerve, you'll have a neurological output. Yeah. If the pregnant woman jumps up and down, the baby starts pushing into the head of the uterus, you'll have a chemical reaction to just kick off birth. So everything is related. Every mechanical movement has physiological and chemical effects. Okay. And so if the structure is impaired, the function will be impaired. The muscles are basically in the right alignment with the right levers to operate correctly, to pump up the blood back up. Yeah. It's just about knowing the anatomy and physiology and a lot of physics to know how the vectorial forces of different structural impairment have consequences throughout the body. Okay, very interesting. What attracted you to this profession? Was there a pivotal moment that brought you? I just went traditionally. I was going to be a general practitioner, so I went to medical school in France. Oh, okay. Okay, so I was there for a few years, then I went to do my electives at Melbourne University in Australia to just have a little bit of a break and see something else. And we went to the anatomical labs, Melbourne University, and suddenly you have one cadaver that's for two people. I'm like, okay, I'm coming from medical school where we have to pass on an arm and have a look, and next year we pass on an entire cadaver to dissect for the next 6 months. So you start by dissecting everything, fashion. I'm like, this is unbelievable, because you start really understanding how the body functions. Because when you look at pictures in 2Ds, you just go, oh yeah, this is great. You don't get an understanding of the architectural network that there is between the tissues. Yes. All the fascial connection that crosses over, and even peeling the skin and all the fascial layers and the adipose tissues coming through. And so you get that. And I found it fascinating. And it's a little bit strange when you say, I'd like to spend a lot more time at the morgue to just dissect and understand cadavers and understand what's happening, because you see those nerves and you go, is that nerve going just there? Is this you start making connections. When you find out there's a psoas muscle crosses across like that, you know, what does it go through from the spine to the hip? Does it go just under the ovary there? Talking about pivotal moment, there is a professor that I really would like to see again, is Professor Chris Briggs at Melbourne University, who said to me, you'd make a great osteopath. Oh. And I'm like, oh, whoa.
Sometimes somebody just sees something in you, right?
Osteopath. So the osteopath, there's a new course starting at Victoria University, and it's Dr. Peter Gibbons, the orthopedic surgeon, who's running the course, and he's a friend of mine. Suddenly I'm like, I'm in the interview, entering the course, and I've got a panel of 5 doctors. I did the interview, and they said, "Listen, we're doing this new course. We're just trying to get osteopathy to a very high level in Australia, and we're going to take 40 out of about 2,000 to 3,000 applicants. So don't get upset if you don't get in." And then I'm going back to France. To go back to med school anyway. To finish the medical files. I don't think much about it. And my dad, at Christmas, gets a fax at his work to say, "You've been accepted into the Faculty of Osteopathy at Victoria University." This is how I became an osteopath. I went to osteopathy. So I left med school, which I got told that I won't be able to come back if I'm going to do osteopathy. I thought it was just blasphemy at the time. But for me, it's just sometimes in life, just something leads to another. Then you're an osteopath and you've been practicing for 30 years.
And one of the best, what's interesting is there's so many layers to anatomy and much deeper than most people learn or ever even get to. Could we go through what those deep layers are?
You've got different layers, but you've got different tissues also. So what you're talking about is tissues. So if you go through the skin, you've got 7 different types of layers in the skin, plus you've got the different types of fascias just underneath, plus you've got the connective tissues, and you've got the muscles, and you've got the vein, artery, nerves, and you've got the drainage system, and you've got the lymphatic system, basically. So you've got all that. But then you've got different tissues in the body. So you've got your neural tissues, you've got your muscular tissues, and you've got your connective tissue, more like your meninges, your ligaments, duras, all the different layers to connect things, but all have a different function. So many of them. You go to the brains, you've got the forks, you've got the tens, you've got different parts of the brain, the hemispheres, the cerebellum, you've got the brainstem, and you break down the brainstem, you've got your cranial nerves attached to the brainstem, how the cranial nerves go back up, how they all interact with each other, how they all interact with the neck, how they interact with the reflexes, how they interact with the vestibular system, the optokinetic reflexes, the neck, the head. So it gets complicated. And you need to integrate all that as you go. You need to just really understand it. It's not that easy. And sometimes you learn something and okay, this is connected to this, there, the trigeminal nucleus goes down, it's connected to ansa cervicalis, goes down the neck, goes up. The trigeminal nerve communicates with all the cranial nerve. And you don't think, and suddenly the penny drops. A few years later, you go, oh yeah, the jaw dysfunction could cause that too, and you build up a repertoire of patterns of how this causes that, and you see those patterns in people, and then you can say, and they go, "It's my jaw." Yeah, I'm treating the navicular on the opposite foot. I know that the navicular changes the hip, changes the pelvis, crosses over fascial patterns that can offset the occiput, because your hip drops, the head will drop like that to the side, and you'll have to recalibrate because your eyes have to be straight. Your jaw is going to shift a little bit, and you have a dysfunction in your disc, in your temporomandibular joints.
Yeah, so your jaw is connected to your foot.
And then people go, wow. It's those things. I had a guy who the only way his jaw didn't dislocate when he sat down is if we put a heel lift. So he had basically a little lifting up like that, so his pelvis stays straight. You do a trial and error, and you find a pattern and mechanism, and you're like, and you don't even know yourself how exactly it works.
Yeah, because all of those layers and everything you just talked about is so detailed.
But you get a feeling that, this should shift there, and it works. You don't know all the time what exactly you're doing. That's the most osteopathy. You have an idea that's as precise as possible, but sometimes the body decides to go one way that doesn't make sense. And if you change something there, it changes there, and you're like, can't understand that connection.
But more often than not, I've seen you understand the connection. What you just done is really explain how deep anatomy is and how deep the structure is when it comes to the function, which people don't even realize. Because literally everyone I talk to is, if you don't hear a crack, they feel like, oh, I don't know if anything happened. Let's go into some of the different types of osteopathy. And if you're, like, for example, craniosacral osteopathy, that's a really common one that people hear about. I think one that you just said to me, I didn't know the name of it, but the visceral osteopathy as well. So if you could just share a little bit about what those are.
So firstly, we call it cranial osteopathy. So craniosacral is a modality that has been developed by an osteopath called Apleja. and it teaches you how to feel the craniosacral rhythm.
Okay.
But we don't
What
call
is
it.
the craniosacral rhythm? Okay.
It's a rhythm that's 8 to 12 cycles per minute. It's part of the autonomic nervous system. It does exist. You can feel it. It's been measured. There's research on it.
Okay.
And what it does, it's like a coil and uncoil mechanism between the sacrum and the base of the cranium, the occiput here. So basically, in flexion, the sacrum goes backwards, and so does the occiput. So it contracts basically the meninges and relaxes the meninges.
Okay.
So that's
in this part of your brain.
That's this part of the brain.
Okay.
But the cranial rhythm, which is called the cranial rhythm, it can be detected in every single organ of the human body, not only in the occiput and the sacrum. That's the craniosacral rhythm.
Okay.
But when the occiput pushes backwards, the frontal bones push upwards and laterally. The parietal bones, push upwards and laterally. The frontal bones goes up and flattens out sideways. Okay, and as if you have two bones coming up. The jaw comes out a little bit. The sphenoid bone in between moves forwards and backwards, and you learn how to feel that.
Oh, okay.
So when you got your hand on the patient, on the head, that's cranial osteopathy. You got your hand on the sacrum. So often, I start with the sacrum to tap into the cranial rhythm, to see how the cranial rhythm feels. And if I get a full flexion and a full extension, and again a full flexion, I can feel this decompression of the body, of the relaxing of the body. The respiration changes. The patient often takes a deep breath and breathe out. Mm-hmm. And when it does that, it's like you bring the patient to neutral, to zero. And that's an expansion of the fourth ventricle.
Okay.
So you've got a blank canvas. Mm-hmm. But that's for me. That's one of my techniques. That's what I do.
Okay. And that's when you're placing your hand on their sacrum or under the butt, basically. And you're feeling that.
I'm feeling the cranial rhythm. I try to feel the whole and how this is connected to the whole and how the tissues are all synchronized with that. Mm-hmm. Now, this is very difficult to learn.
Yes, I haven't seen many people.
It took me years to. So if you look at babies, they have different patterns.
Yeah.
The way they're like, the head is twisting. That is called parallelogram patterns or a sphenoid torsion. How? Going back to the principle, structure governs function. How the structure affects the function. So with babies, it's a dream because you can see the baby, you decompress them, and suddenly the nervous system comes down and the baby relaxes and falls asleep.
But just simply placing your hand underneath it does that, or do you actually do something there? Because I sat there for 20 minutes before and you've just placed it. I felt things happening, but I didn't know how.
So I generally wait for that time where the body just takes this breath and breathe out and it resets itself. So the nervous system relaxes. You trigger the parasympathetic nervous system. Mm-hmm. So basically, you get the patient out of the sympathetic load. They say, boom, suddenly they relax. They feel their body relaxed. It's much easier for me to work afterwards.
Okay. So would you say that then the osteopathy actually can address some chronic stress that's going on?
Absolutely.
Like mental chronic stress also.
Absolutely.
Yeah.
You working cranially on a patient and really having a full cranial or biodynamic treatment.
You start with the craniosacral under the sacrum to set the person into parasympathetic mode so then you can start to actually do the work that you need to do. How do you feel that some of these restrictions that show up in people's body, right? What kind of problems do you see most commonly, especially among women who might be going through different sort of transitions? Maybe they're going through pregnancy or postpartum, or they're going through menopause. Like, where do you see the restrictions of fluid flow?
Yeah, you've got tissue, you look at everything. You look at tissues, you look at tissue tension, you look at asymmetry, you look at basically how the body, the rebound, the body is, the tenderness of the body. But in women who are either going through pregnancy, postpartum, even in women in general who work a lot, even in men in general who work a lot. The tension these days is often located into the lower abdomen,
Okay.
into the hip flexors along the psoas and along the diaphragm,
Okay.
due mainly to long-term sitting postures.
Okay.
And you see a lot of compression at that level. Okay.
What kind of symptoms do they have in that you see show up the most? Like, what are they coming to you complaining about then?
Usually I have people that come to me complaining about their neck. I feel there's a lot of tension in my neck. And I have a look and I go, okay, where is that coming from?
Me, yes.
Okay.
Yeah.
But then you look at the whole body. You look at the hip flexors are pulling there. You look at the diaphragm being compressed. You look at people that sit at a computer all day, just like this, and sitting all day. People were not sitting all day 100 years ago. This is a fairly new thing in the history of humanity.
Yeah.
And I believe personally that the compression that you have, the anterior tissue, the anterior fascial strains, as I call it sometimes, or the compression, and it can affect the breathing, which affects gastrointestinal function. IBS is definitely responsible for part of that. You're compressing everything, you reduce drainage, everything is more, the stasis in the gastrointestinal tract increases, and the hip flexors tighten up. The compression on the reproductive system is more present. The ability to just open up the hip flexor and just make sure, this is why I start a lot with sacrum, because opening up the pelvis and decompressing the pelvis can just open up the body anteriorly at the front.
Okay.
Which is a very common problem at the moment because of the sitting posture that people have daily. If you work 12 hours a day at a computer,
yes,
you're not designed for that. With a neck problem, they're coming with a shoulder problem, coming with a back problem.
Okay.
For the first consultation, I ask them, is there anything else you need to tell me? How's your digestion? How's your sleep? Do a quick scan. Do you have regular periods? You quick scan all the systems.
Yes, yes.
And they say, oh yeah, I've got IBS severe, but I've been that for a while. Okay, note to self. I know they want me to address their neck, but I know that I need to check the diaphragm. The diaphragm is innervated by C356. The phrenic nerves comes from the neck. So boom, instantly I make that connection. Diaphragm, neck. Okay, his digestion is good. Oh, do you exercise? Oh, not really. Okay, he doesn't exercise. His diaphragm, what is he compressing? What type of IBS do you have? Constipation or diarrhea? Oh, mainly constipation, but there's certain food that I can't eat. Oh, okay. What type of food? Since when? Okay. Oh, yes, his pregnancy, I can't. And you just stack everything up and you summarize everything, and in your head you build up that picture of the patient. So in women, you have postpartum, for example. One of the classic things that I see with women postpartum, especially with women who suffer with a little bit of postnatal depression or feeling overwhelmed.
Yes, that's such a common problem.
With their baby, for me, there's a high correlation with C-sections.
Ah.
Okay, so I've been thinking about it a lot, and I've been thinking about it I was at a mechanical level. So mechanically, you have the baby that's stuck in the pelvis for a long time. The body is going to give birth. So it's just the Braxton Hicks just practicing to give birth. Contractions happen just a few weeks before the birth, or even up to a couple of months before the birth. Gathers the power. The hip flexors tighten up. The psoas acts like a railing system. The psoas is attached through the crura up the fascia, goes through the diaphragm. Everything compressed, everything tightens up. It's like launching something, ready to just push it out. So he practices that. Then you go into labor. You have contraction. Ready to launch. Contractions get closer together, closer together. We're ready to gather the momentum and the force to push through. It goes out there, boom, epidural, C-section.
It just stays stuck.
Everyone's stuck. The mum comes out. She hasn't had that release. And the push releases different hormones too.
Yes, of course. Yeah.
The push is necessary. It's a completion of the process. So in women who haven't had that push, who had a C-section, you treat the diaphragm and it's stuck up there. Everything just compressed up there, and they feel so overwhelmed and stressed with the baby. They can't connect. They can't attach this. They haven't had that endorphin release that comes
Yeah.
with the joy of the birth sometimes, and that slight disconnection can cause that start of a little P&D.
Yeah. Postpartum depression. Yeah.
Yeah, postpartum. The other thing that I've been thinking about a while ago, I started thinking more mechanically, now I'm thinking more on a fluid level, but if your sacrum is being affected and you have a torsion when you push, because when you give birth on all four videos, your whole pelvis just decompresses, just like these, what's those, transformers, things move, and it's like impressive. The sacrum actually pushes up. You can see video of the sacrum just pushing up
wow.
and a slight torsion of the sacrum when it comes back, or even when you've got the pubic symphysis, it opens up and comes back, boom, everything coming back slightly off at the pelvic level can cause a twist in the sacrum that has repercussions all the way to the sphenoid bone. And the sphenoid bone's got the pituitary gland that sits in the middle.
Oh.
So if your pituitary gland is sitting more to the right, more to the left, your hormone, the compression on the pituitary or the pressure on the, what we call the clinoid processes, like a little cage of the sella turcica, starts pulling and potentially could affect the function of the pituitary. If you look at the structure governed function,
and this is
if it's not in the right spot
during the natural birthing process.
During natural birthing process.
Yes.
So there's different.
So then, if that gets compressed or affected during the natural birthing process, that affects also your mental.
It will
just
affect
for layman's
your hormones,
terms of it.
It will affect. Now that's a theory still of like
Yeah.
how the structure affects the function, but you have to think about all that when you look at the woman who's just given birth, or the woman who's just heavily pregnant, or the woman who's got sacroiliac dysfunction during birth and just finds it difficult to walk because the hip cannot put weight on the sacroiliac joint. You have to think about the consequences.
Interesting. So it's really, there's a huge mental connection between the process of giving birth and how you're, like you said, how the structure impacts the function. So even your glands can be impacted during that process.
Your glands could be impacted. If you've got a gland that's being constantly pressed, it's going to react to it somehow. It's going to maybe secrete something, or these glands, it's the neuroendocrine system responds to electrical stimuli. And electrical stimuli responds to just pressure also. You can block it and enhance the neurological stimuli by just compressing something.
Pituitary gland is very much responsible for a lot of our hormonal signaling and messaging in our body.
Yes.
So if postpartum that's impacted, then of course you need to come and decompress or do the structural fixing. Welcome to the Thrive Tribe podcast, a place to discover a community of practitioners who can support women to achieve good health beyond just the traditional methods. It's also a place to empower women with the knowledge they need to better prepare their body, mind, and spirit at each stage of their life, from periods through menopause. I'm Chandani Motwani, your host and functional nutritional therapist. I look at each individual's unique needs to manage their long-term health challenges and prevent future issues long before symptoms appear. Our body whispers. I work together with you to identify those signals and address critical areas to set you on a path of vibrant health and vitality. Our sponsor, Blissamy, is your personal health companion, a smart platform that blends your biometrics, life stage, and wellness goals to create a tailored health journey just for you. Whether you're navigating women's health, chronic care, or mental well-being, Blissamy guides you to the right holistic providers, products, and programs all in one place. We just talked about postpartum, but what about other transitions in our life, right? What about at a time like menopause? Like you're transitioning, there's hormonal changes. Our bodies, like women's bodies, can start to really get in a lot of pain. The neck problem that you also come in with shoulder problems in perimenopause, I'm sure a lot, and like bone density issues and everything. So where are you seeing the root causes of something like that?
The hormonal change in menopause has a systemic effect. So that means it has an effect on the whole system, on all the tissues in the body. And you see it, like the classic example is frozen shoulder. So in Cantonese, it's called the shoulder of the 50-year-old.
Okay.
Okay. Now, for years, like I remember when I started practicing there, like I was looking at the research on frozen shoulder, and the most conclusive research was that it was a Dutch research, and it showed that the adhesive capsulitis, which is a frozen shoulder, is most likely related to diabetes. And I was like, wow.
Interesting.
Basically, the correlation that you had with frozen shoulders happened, the ratio was 3-1, women to men, from 45 to 55.
Yeah, and that's the menopause ages.
That's the menopause age. Okay. So what happens at menopause? The hormones change, the tissues start to tighten up. All the tissues respond to your hormone. And you can see that some people get stiff, get tight, get that. Your instinct as a practitioner, even as an osteopath, the human instinct is to go to where the pain is. Oh, shoulder's not moving, I'm going to move it. But you try to move a frozen shoulder and the tissues say, cannot, you're not moving me. And the patient says, it's not going to move. So you go back, you say, what are the tissues who are locking that shoulder? And you go down the anatomy, and the ones that I started treating, I was, latissimus dorsi is a muscle that goes down here, the pain's here, it goes all the way down to the mid-back. And I was talking to an older osteopath, he goes, oh yeah, if you go and mobilize the middle of the back, the thoracolumbar junction, T12R1, you'll get results. Yeah, we'll free up latissimus dorsi. I'm like, okay, go and crack the back. You get better results. You don't get results. And then I started treating, if you treat the hip flexor in the opposite shoulder, you get results too. Because the patterns of the fat connective tissues zigzag like that. There's an osteopath or anatomist called Zink. He wrote a book on fascial patterns in the 50s. So if you look at that, how the body compensates, the body often, not always, compensates contralaterally.
Okay. Yes.
So if you treat frozen shoulder, I started treating the hip flexors and the opposite hip, and I got better results. What lies under there in the pelvic bowl of the opposite hip? The ovaries. Are the ovaries also shrinking, connecting, pulling the tissues up so much it tightens up on the opposite side? And then you start thinking about all that. What's happening there at a reproductive level where the hormones are depleted and not creating, because the ovaries have got no use anymore.
So they actually shrink a little bit.
They shrink a little bit.
Ah, okay. And then that might pull on.
And there's the pull, and there's fibroids that can happen.
Yeah.
Even with hormonal imbalance. Polycystic ovaries, hormonal imbalance. You've got fibroids, you've got pulls. You need space with tissues around.
So decompressing that pull from your ovaries in that pelvic region almost has in your practice, you've seen it reduce frozen shoulder.
I just go back and work, as I said before, on the hip flexor, so on the psoas, because the psoas attaches up to the thoracolumbar junction, which cross patterns with the latissimus dorsi.
Okay.
So you look at further down, and this is what I have now, but I'm sure in about 5-6 years' time, the implementation will evolve because you keep digging why this is happening. Yeah. But I can now confidently say, I'm going to treat that frozen shoulder and I'm going to fix it.
Because you've seen...
Because I've seen the patterns.
Yeah.
And I know how it works.
So that's fascinating. So your hormones are changing. That's changing how the fluids and the tension of the muscles, everything are working. Because your organs
tissues, muscles, because you're...
And then that's causing issues in different parts of your body, which frozen shoulder is one of the most common ones during your 40s in women. But I know you mentioned diabetes. Did you see that connected at all?
Well, basically what I think is that they just related it to hormonal changes. So when I went back to it, I'm like, they just tapped in, there's a change in insulin or glucagon, and it's affected people who've got frozen shoulder but not to have diabetes, because at that time the hormones drop, it affects your neuroendocrine system, and everything's linked. Your metabolism drops, you're more likely to get type 2. I'm not really sure, but I think that they found a strong correlation with that.
What I'm understanding is that adjusting the psoas muscles, adjusting that in the pelvic region is helping the frozen shoulder, but can adjusting that impact change how your hormones are playing, or you don't think so? It's not the other way around. In the postpartum example that you gave, it would impact because your pituitary is then less compressed.
It would, but when you're going through menopause, the change of hormones is systemic. It has to happen. It is part of life. So
here we're just managing more the symptoms.
You want to manage it and make them comfortable. And every woman is affected totally differently with menopause.
Yes, absolutely.
Okay, you've got totally different. Some women, it's like, oh, I don't know what they're talking about. I've just had like hot flashes for a couple of days, nothing else. Some women, I don't have any hot flashes, but they're extremely tight.
Yeah. Some
women are extremely moody and have really brain fog, like they can't think, they can't do things. It totally depends. So I think that HRT is great. I think that it should be really talked about earlier to help balance women who are going through this, definitely. And I think it had a really bad rap a few years ago, especially when he said, oh, it was associated with breast cancer. But I think that at the moment, the narrative is more like, hold on.
Also, the type of hormones we use now are different.
Totally.
So there's definitely
hormones and all that stuff. Yeah. It's totally different, and they're much more targeted, and you can control them. The problem with hormones, it's very difficult to control because every single person responds differently to an amount of hormones that they need. Okay, it's like giving thyroxine, levothyrox to someone with hypothyroidism. You just don't know. You just need to tweak it. Okay, so menopause is a little bit the same, but it is a game changer. I've spoken to a lot of women about it.
Yeah.
HRT is a game changer.
Absolutely. It completely changes how you feel. Yeah. I've seen my own family members go through it. So yeah.
And it saves, the further things, the women feel much better. Their tissues relax. They go through it. Once they've gone through menopause, it's okay afterwards. It's just that transition that can last for 10 years.
Yeah.
Unfortunately, it's a long process.
Yeah.
But it needs to be addressed, talked about.
Yes.
Women need to be educated on, because when a woman is in perimenopause or in menopause and they have those symptoms, sometimes they don't know. They think it's the stress.
They have no idea. Yeah.
Of their work. They think it's the husband, the children that's stressing them out. They don't know. Okay, you're the last person who will find out you're stressed. Everyone knows you're stressed
before you.
You don't know.
Yeah.
So it's the same. So it needs to be talked about. I really feel that there's some education that needs to be addressed around it, and really just also tweak with certain hormones, just finding out whether you need to address a progesterone, testosterone, estrogen, balance them out properly, and try with men, take these women through that journey.
Yeah.
I'm not an endocrinologist and
of course,
an obstetrician, so I work with these people, but I do recognize the women who have got chronic patterns of tight tissues, inability, insomnia, inability to think straight, quite emotionally distressed. I say, listen, we had a few treatments that it keeps coming back. Okay, so I work with a lot of doctors to say, hey, can you just check the hormone? Let's check your hormones levels. Yeah, you could just have a hormone imbalance.
One thing that brought me to you is that when I was having trouble conceiving and getting pregnant myself, you identified a fertility issue that no doctors, and I think it was a bit of an oversight on some of the doctors, but you identified it in a very unexpected way. A polyp blocking my right fallopian tube, completely blocking it. And nobody had told me that for 3 years, even though they had seen it growing in scans, but no one had told me. And I was going through so many different fertility treatments. And I actually came to you after a ectopic pregnancy that I ended up having, right? How did you feel that? You literally put your hand under my sacrum and told me, hey, it's not the left side where you had the ectopic. I think there's something going on your right side.
Yeah, okay.
And how did you feel that?
So when you start the consultation and you just saying you try to find the neutral, the body, you just get the body to just relax and find neutral. Sometimes there is a restriction that's there and stays. So it's like everything relaxes, but this part doesn't want to let go. And you feel a slight pull going to that side. And you feel that compression of that hip coming through there. So the tissues are suddenly just changed. They're changed because there is a pressure there that's obstructing blood flow.
Okay.
So you go, okay. So then you go anatomically through all the tissues going there. You go, oh, your ovaries are sitting there. You got your fallopian tubes and so. You got your iliacus going through. So you've got your pelvic floor. Okay, and you go up. Oh, you got the hip flexors, and you see that pull there, and it's like, what is going on there? Okay, so then you just go, I'm going to try and decompress that hip to create a little bit of flow. So you go and decompress the hip and tighten, and it tightens back again.
And so that's how you knew something was wrong on
So
the
you
right.
know, like, the tissue doesn't feel right here. I know that the tissue, I would be expecting more like an inflammation and adhesions and tensions on the other side. Then I feel it on this side. And I check the pelvis and I say, is there an imbalance in the pelvis? It's twisting to one side, the levers of the muscle, and some of them are under tension. No, I don't have that. Let's go and check out what's going on. Is it a fibroid? Is it a polyp? Is it something that's happening there?
From a fertility perspective, what problems have you seen women come in with? I had a polyp blocking my right fallopian tube, but what other things have you seen, and how does the readjustments impact fertility?
Usually the most common cause of infertility, in my opinion, is stress.
Okay.
So it's high cortisol levels. It's women that work hard and they're constantly under high cortisol levels, under stress. And I use that example a lot with women. That nature does not allow a human to get pregnant if he's under stress. Mm-hmm. I think I told you that at the time. You will not.
I was working really hard, and then I stopped actually working that
stop.
hard.
Yeah. And I usually say, if you're in the jungle and you're being chased by a lion, there's no chance you're going to get pregnant, okay? Because the body's going to go, first of all, we're in flight or fight. We're going to survive here, okay? So we've got no time to procreate. If everything's secure and safe, then you get pregnant. Then your parasympathetic will kick in, your sympathetic will drop, and everything opens up. Parasympathetic is opening. Sympathetic is tightening up and run.
Everything's going to be tight, so your blood flow is not going to be
blood flow is not going to be there. Makes sense, right? So you go and you have a feel of what's happening in there. You trigger the parasympathetic system. You get women off exercise also. Women who exercise too much don't get pregnant. Okay, women who are athletes who just do crazy amount of exercise, sometimes they've got their periods with despair, right? Or really little periods, because the body cannot afford to lose iron. The body needs oxygen to exercise, and we're not in a position to just get pregnant anyway. Number one thing to do is just trigger the parasympathetic nervous system. And then you work on the uterus. You do visceral osteopathy.
Oh, okay.
So you work on the viscera.
Okay.
So you release the fascial tensions of the uterus. You open up the fallopian tubes with the round ligament. You just decompress the round ligaments. Make sure that everything is working properly and the flow can happen from the ovaries down the fallopian tubes to the uterus to go and meet the sperm. If everything's like this and nothing's working, you want everything to open up.
Okay.
Pretty simple.
I came to you before I did my embryo transfer, and I do remember feeling very relaxed.
Yes.
And I think that it makes sense to me from an experience perspective, especially. So
it usually takes, if you explain to the patient what's happening, what you're doing, and you need to have some really simple examples to make sure that they understand. Once they understand, then they can just relax into it. I was at a dinner sitting next to an 85-year-old obstetrician, and someone asked him the same question: what's the number one cause of infertility? And he said, stress. If people meditated, they would get pregnant.
I was meditating though a lot.
That's what he said.
Yeah.
Okay, but he was 85. He was wise, and all the doctors were like, "Oh yeah, sure."
But sometimes the stress just lives in your body, and you need to.
It stays.
Yeah, it's so hard for it
stays for years. Yeah.
Yeah, it does. Or there's something that, like you said, like a polyp, or like in my case, polyp, or some kind of structural inefficiency that's causing a pressure or press or something, which was in some people the pituitary gland, you said, right? So is there some advice you could give to women who are going through this fertility challenges? What would you say to do? You're saying to relax, but what can they
it's difficult to say that, because everyone's got to do some work, everyone needs to have a living, wants to just But the best thing to do is to just really let it go. I had a practice manager who was also a personal assistant at the time, and she said to me, listen, she said, I'm 38 years old. I've been trying to get pregnant for 10 years. It's not going to happen. Okay? We've done everything. I spent $1 million on everything. It's not going to happen. Oh. I never even asked her whether she was going to get pregnant or not, but she just said straight away that. I'm like, oh, okay. She got pregnant with me. And one day she had a sore back and I gave her a treatment and she totally gave up on getting pregnant. And about 8 months later, she comes to me and goes, I need to talk to you about something. I'm like, what? She goes, I'm pregnant. I'm like, holy. I'm like, Naturally.
Amazing. I've heard those kind of beautiful
And then she's
stories.
had 2 kids. So basically,
Wow.
she's had 2 kids back to back. And she let it go. She let it go that she just relaxed about it. And maybe when she got treatment, I had a few patients who couldn't get pregnant and suddenly they get a treatment for their low back and
release the tension,
you
get the
release
flow,
the pelvis, but the flow kicks in and bang, they get pregnant.
That's great.
It's a side effect. And I had one, she went to, yes, this is, you're pregnant because of this guy. I'm like, hold on. This is how rumors start. You know?
Yes, oh, that's great. Yeah. I've also come to you postpartum. So when you were talking about the diaphragm, I had a C-section. So I did feel that overwhelm. I did feel very connected to my child, but I felt that deep sense of overwhelm that you talked about. So that we discussed. It's like you need that release. And so osteopathy can help relax those muscles. But as a new mother, I came back to you with what I used to have, tennis elbow, you fixed years ago, right? And now you fixed it again. So osteopathy can also seem to help with repetitive stress injuries as well. All of this kind of stuff happens, especially as a new mom or as a postpartum, because your body is going through so much and you're constantly holding a baby.
You're constantly holding the baby and you're constantly holding your shoulders. And you're constantly, these decurveins, tendonitis, again, it's the same as that. You open up and it pulls. You're holding like this. Everything up there compresses. Also, you're breastfeeding, right? So you got your posture there. It pulls on the clavipectoral fascia.
So much
pulls
pain
on
here.
there.
Yes.
So the neurovascular bundle of the brachial plexus gets affected. Underneath the subscapularis muscle tightens up because you're always internal rotation.
Okay, just for everyone listening, it means shoulder, underarms, back, from the back.
Everything tightens up. So this area gets blocked.
Yeah.
So what's going to happen in the extremity?
Yes.
Reduce nerve supply, reduce drainage, reduce nerve supply to the nerve.
Yeah.
There.
And I can't be more grateful. I used to teach yoga before I had a baby. I used to do quite a bit of exercise, weight training, everything. No matter how much I felt like, okay, it's been now 6 months postpartum or 1 year postpartum, I just couldn't get back to my state of being able to move and exercise. I'd go to a yoga class and my hips and my arms, everything hurt. Doing a handstand or headstand was out of the question. And I came to you for 3 treatments and everything just opened up and this elbow stopped hurting. And I went to a yoga class the next time and I said, oh, this feels like it used to feel like. Just for new moms, there's hope because
it doesn't need to be. People think that it's going to take a while the body can recalibrate very quickly.
It was amazing.
As long as you just
3
treat
weeks.
the cause.
Yeah.
If I treated your tennis elbow by just doing some dry needling or extension, it wouldn't happen. You need to treat the body as a whole. You need to keep in mind that the body is a functioning unit and that wholeness is not a fact, it's a reality. Every tissue affects every part. And you have to be able to connect the dot. You cannot fix a tennis elbow without treating the neck. It's impossible.
Yeah.
Or the shoulder, or the upper thoracic, or the ribs, everything. And then you work your way around it.
Yeah, I did. I remember you worked a lot on my...
The diaphragm attaches further up. I mean, the upper thoracic coming across there. It's innervated by the neck, as I said before. So you get the connection. Diaphragm pulls on the side. You've got the phrenic nerve coming back up. Shoulder problems, diaphragm problems go together. Gallbladder refers pain to the shoulders through the diaphragm. There's all that. The connective tissues up there. So you need to keep in mind that the body is a whole. And then you've got more chance of fixing it.
This has been a really great conversation. I've actually learned quite a bit and really understand how our body is actually so much in tune with how we're feeling emotionally as well, right?
Yes.
If your hormones are changing, then you're finding pain in your shoulders and releasing that can actually release all the stress and all the tension. Or for me personally, coming to all of the diaphragm adjustments and the tennis elbow adjustments, I can now function as a new mother in a different level than I could before. Osteopathy can hit you at the chronic stress level, where you can really, if you change that chronic stress that you're experiencing in your body,
you regulate the nervous system, you rebalance everything, you make sure that the body functions optimally.
And if you regulate the nervous system, make sure the body functions, what you've described is what we think is magic, and sometimes even to you is magic. You feel like, oh, I don't know exactly how that got fixed, but it did. But it's basically a domino effect through the body.
Domino effect. And the body's got the ability to heal itself.
Yeah.
So you put it on the right track, and sometimes, I know where it is, it goes.
Yeah.
It goes faster than you.
Yeah.
Great. Always.
Amazing. Any advice you want to leave for women who are going through these transitions in their life that you think?
I think that one of the most important things is to talk about it with their partners, for their partners to understand it. Because a lot of men don't understand menopause. They find it very difficult. The way of thinking between men and women is quite different, right? So they are quite linear, and menopause has got a bit of a stochastic kind of effect where too many things happen at the same time, right?
Yeah, yeah.
And the men who are quite linear find it very difficult to deal with.
Yeah.
And they shut down. And you see a lot of separations between the age of 45 and 55 due to that.
Yeah.
So...
And then remarriages at 55 because you figured yourself out.
understanding that and just helping their partners through the journey is super important.
Yeah, very good advice. Thank you so much. And it was wonderful to have you here. I will put a link to Damien's practice. It's Central and Stanley Wellness. He has a thriving practice, so call ahead of time if you are in Hong Kong. If not, then we really encourage you to go see an osteopath. I've had amazing experiences in my life going to Damien and other osteopaths as well. Good luck and take care of yourself.